We'll move. We should take a few minutes. Robin, good to see you. Appreciate you being here, bringing your presentation, your wonderful staff. And we'll turn to you for the beginning. I believe we have your handout on the wall member. And again, welcome.
Mr. Chairman, you got time for a really short story?
Absolutely. Oh, that's humorous.
Back in the dark ages, when I was vice president of Northeast Louisiana University in Monroe, Louisiana, I had to go to Baton Rouge about once a month, either to meet with the Higher Education Board or the legislature to try to get funds, et cetera, et cetera, et cetera. Well, I always took Highway 15. It goes down from Monroe across the river to Natchez and goes on down to Baton Rouge. Well, one morning I was coming down 15. It crosses the river, the Tensas River, in Clayton, Louisiana. And I hit that bridge there about 60 miles an hour, looked up, and there was a 35-mile-an-hour sign in the middle of the bridge. And there was a quintessential small town lawman on the other side. And he had a straw cowboy hat on, he had sunglasses, a small cigar in his mouth, he had khakis on, he had cowboy boots, he had his khakis stuffed down his cowboy boots, had a butterbean stomach on him, and he had some paraphernalia buckled on him below his butterbean stomach, and a 357 Magnum looked like it's about 2 feet long. So he flagged me over and saw me. "Where's your license?" "Here, sir." I couldn't think of anything else to say. So I said, "Sir, did you realize that section 55756.30 of the federal code says that you have to have a warning sign far enough in front of changing the speed limit that a driver can take his foot off the accelerator and decelerate to the posted speed limit?" He didn't hesitate. Took a cigar out of his mouth and bent over. And he said, "Sir, did you realize Section 1 of the Clayton Code says I'm fixing to give your ass a ticket?" And he did.
The moral of the story is?
The moral of the story is don't try to
meddle with authority.
Fool the good Lord.
There you go. All right.
Now, gentlemen, ladies, you want me to proceed?
Don't mess with the man with the cowboy. That's right. Don't mess with the man with the cowboy boots or the hunts alligators. All right, Dr. Clyde.
All right, we thank you for this opportunity to come over and present our budget to you. We have been working very hard at Medicaid. Healthcare reform is dumping a lot of additional stuff on us, and the staff has responded very well to that. And we try to be frugal, and we try to serve our beneficiaries as they should be served. Put those on the road that should be on the road, and give them the right service at the right price. And with that, I would like for you to allow Margaret to go over the budget with you. And if you would, please wait till we get through to ask questions. You're the bosses, and if you want to interrupt and ask questions, that's certainly your part.
Thank you. That's what Code Section 1 says about this committee. All right, we'll recognize the young lady.
Good afternoon. I'll start the Division of Medicaid's presentation by asking you to turn to the second page in the manual. This page provides a summary of the direct state funding for Medicaid requested in fiscal year 2013. Can y'all hear me okay? House Bill 1499 appropriated $763 million for fiscal year 12. So we started our request with that amount. That was made up of general funds in the amount of $169 million, $112 million in tobacco funds, and $307 million in budget contingency funds, along with $175 million in reappropriated funds. We're requesting $107 million $11,706 additional dollars for direct state funding for fiscal year 13, which brings us up to a total request of $870 million. The additional request is broken out as follows. The first year expense of the multi-year MMIS procurement project was funded in FY 2012. However, the funding of $4.8 million was made part of a bond bill and was not included in the $763 million of appropriated funds. Included in our request is the replacement of one-time monies using state appropriated funds to ensure continuation of the new MMIS project. We greatly appreciate the legislature's support of the new MMIS computer system. The current MMIS technology is over 10 years old and is the oldest in the CMS region. Traditionally, we have not included an estimate of the offset in funding needed because of the reduction in the federal match rate, because CMS does not provide the estimate this early. However, because a reliable estimate from FFIS was available, we did include this amount in our request. The projected change is a decrease to the Medicaid federal match rate of 1/3 of 1% and a decrease to the CHIP match rate of 0.23%. These decreases require an increase in direct state funding needs for Medicaid and CHIP of $18 million based on our projections. Also related to CHIP, our request includes $3.3 million for growth-related.
Chairman Hahn, what will the FMAP be for the next year exactly?
The projection for FY13 is 73.85%, and the FY12 projection is 74.18%. We haven't gotten that officially considered.
So that would mean that we are doing a little bit better economically in Mississippi then, because it's based on the federal poverty rate.
Also related to CHIP, our request includes $3.3 million for growth related to premiums and participant increases. The current contract between DFA and the vendor allows a 5% increase in the premiums this January 1st. However, the contract does not specify the cap on the increase for the following January 1st. And that will be up to the insurance board to determine what that will be. A steady growth of the children eligible for the CHIP program of 1/3 of 1% per month was applied to our projection CHIP expenditure growth. The state funding request for CHIP expenditures totals $41 million for fiscal year 13. Our request includes $5 million for growth in Medicare premiums. We applied the projection of Part A and Part B premiums from CMS to the expected population growth of 0.28 of 1% per month, which is expected to remain steady. The Medicare Part B fallback payment is 100% state funds and is expected to increase due to rate and duly eligible beneficiary count increases. But any increase in the provider taxes results in a direct reduction of the request for direct state funds. Based on the requirements of state law, provider taxes will increase by $18.75 million in FY13. Likewise, any increase in matching funds from other state agencies and UMC reduce the request of funds made directly by the Medicaid agency. By state law, the other state agencies and UMC must provide their own state match for all medical service expenditures. Though this increase represents a decrease to the Medicaid agency request, an increase in direct state funds will be required in appropriations to the other state agencies and UMC for these increased medical service expenditures. In summary, we are requesting an additional $107 million for a total request of $870 million in state funds.
Representative Watson, first.
Yes, if you could go back to the replacing the bond funding. I really don't understand that. Perhaps I should, but we actually allocated $4.5 million for this particular system, I thought.
Well, it's a multi-year project.
Okay, this is the second year.
Right, FY12 is the first year, FY13 will be the second year.
Okay, so we only, I guess, funded a little less than half of the amount that you need to fully pay for this. That's it.
Well, it's definitely less than half, yes, sir.
Well, then, you're saying less than half? Okay, thanks.
Chairman Holland, you have a question?
On the UMC match, what was that figure that you gave us, please? It's $19 million that they're requesting, I believe.
Well, this was only the increase over prior year, over the 12 amount that we had budgeted. And along with Department of Mental Health, it's the $9,082,492 number.
How would the division feel about taking care of all the match on community mental health centers?
We don't care where the match comes from as long as we get the match. The legislature has a law that has to come from them. And as long as that law's on the book, of course, that's where it's going to come from. Now, you can run it through us if you want to, do whatever you want to do, but we have to have the match. And I'll tell you something you need to be very cautious about. If you start running that match through us, we're going to have to control expenditures to some extent with the regional mental health centers because they will spend a lot of money and we'll run out of match. And we'll have to come to you for deficit appropriation.
Well, the fact of the matter is, it really don't matter, Director, as you said, where we put it, but the fact of the matter is, most everybody in our Medicaid system is a provider, and we pay on a fee-for-service basis. So why shouldn't the Department of Mental Health, regional mental health centers be the same, and you would exert the same kind of quality control over them as you would any other provider of a Medicaid service?
We have no problem with that.
Other question? Please continue.
This pie chart reflects our FY 2013 funding from all sources. These sources make up $5.96 billion total request for the Division of Medicaid. Note that the $870 million request in general funds makes 15% of the request. 76% will come from the federal government. 6% is made up from the provider taxes, and the remaining 3% is expected to be funded by the other state agencies and UMC through other funds. On slide 4, this bar chart presents direct state funding since 2007. All sources other than general, tobacco, and budget contingency funds, which are shown in red, represent one-time monies. As you can see, there were a lot of one-time monies during this time period. No one-time monies are expected for either FY12 or FY13. This slide reflects total medical service expenditures for the past 5 years. The blue shaded areas represent medical service claims, shifts, and non-emergency
There's
treatment.
just one quick question on 13. You're talking about one-time money. In your budget request, on the first page, you're assuming that we're going to replace about $593.5 or $4 dollars of one-time funding in that request.
Well, I guess what I really was talking about, yes, sir. What I was really talking about on this next slide is one-time federal funds that replace the need for state funds.
But we're going to have to replace that 593.
Yes, sir.
All right. So that's All right, go ahead. Yeah.
Yeah, on slide 4, we're just trying to point out that we've had Katrina funding, ERA funding in the past that have taken the place of leads for state direct funds. We don't expect to have any of those sources in FY 12 or 13. On to slide 5, which includes the blue shaded areas, medical service expenditures, CHIP, and non-emergency transportation services. Does not include hospital fish or supplemental UBO. This amount grew from $3.15 billion in FY 2007 to $3.9 billion in FY 11. This increase is due to an increase in beneficiaries and utilization, plus healthcare inflationary costs. The red shaded area represents Medicare premiums for Part A and Part B and Department Fall. Next, we are showing you how much Medicaid has paid our major Medicaid providers from fiscal year 2007 to 11. In FY 2011, from all sources, we paid hospital providers $1,636 million. To our nursing facilities, we paid $738 million. To pharmacies, $309 million. And to physicians, $349 million. Annual averages of our Medicaid beneficiary counts from fiscal year 07 through 11 are reflected in this bar chart. Our average enrollment count during fiscal year 11 was 631,083. As of August 31st, we had nearly 639,000 Medicaid beneficiaries enrolled. The counts grew by 16,000 over the year, and we are seeing growth of about 2,000 per month. These counts do not include CHIP, as they'll be shown on a different slide. This reflects the average cost per Medicaid beneficiary. You will note that the average cost has escalated 5% from fiscal year 10 to FY 11. Now we're showing you the year-end counts of CHIP beneficiaries. At the end of fiscal year 11, the number of children eligible for the CHIP program was 69,669, which is up from 67,336 children in June 2010. We show the average cost of CHIP beneficiaries for the past 5 years. For FY 11, the average annual cost per child was $2,751. I would like to point out that the average cost for a comparable Medicaid child is $2,300 for 2011. As you may know, we pay for CHIP services on a per member premium. The average premium for fiscal year 11 was $232.62. The actual cost for Medicaid to serve children that are comparable was less by $41 per month. Here, we will go through a comparison showing persons served in nursing facilities with their associated costs to persons served in home and community-based services waivers and their associated costs. While we understand certainly that the cost of serving a critically ill person should be greater, the chart does depict that it is much less costly for our beneficiaries to be served in a home environment. This fiscal year, for the first time in program history, we expect the number of people served in home and community-based services to exceed the number of people served in nursing facilities.
Chairman Hall.
Are we asking for enough money to fund all of the slots that are allocated at this point in this budget?
Yes, sir. Next, we have a comparison between persons served in the waivers that BLM operates and the funded slots. The reason you see a greater number served than funded is that more than one person can occupy a slot during the year if a slot is vacated. As you can see on the left and right charts, the number of funded slots for both the E&D and MyPAC waivers has increased for fiscal year 12. We also want to let you know that as of August 31st, the E&D waiver had 12,359 people on the waiting list. No, on waiver services, with 3,687 on the waiting list. Those on the waiting list are being evaluated, and the PDDs continue to increase staff to accommodate these needs. We are currently working with CMS to renew 2 waivers. We are requesting an increase in the assisted living slots through this process. As shown on the middle chart, the assisted living waiver is currently serving 400 people. We understand that a request of $870 million for state match is a large amount for our state budget. We thought we would take just a moment and talk about what is facing us with healthcare reform. In the second column of the slide, June 2011 actual enrollment is shown. The changes created by the Patient Protection Affordable Care Act, also known as healthcare reform. Increases in enrollment to over 1 million beneficiaries are projected. An increase of between 310,000 and 420,000 in eligible beneficiaries has been projected for Mississippi by National Actuarial Firms. The projections from Milliman, shown in the upper portion of the slide, are broken out by category of eligibility. Kaiser did not present the information in the same way. We have shown Kaiser's projected increase in adults at the bottom of the slide. As there were previous concerns that Milliman's expansion projections were high, the Milliman information has also been compiled at the bottom of the slide for a comparison to Kaiser's. Healthcare reform eligibility changes, which are right around the corner, begin January 1st, 2014. DOM contracted with Milliman also to provide us some projections on costs. They estimated the total fiscal impact to our state budget through fiscal year 2020 to be between $0.9 billion and $1.7 billion, depending on the actual level of participation by the eligible population. The firm did not include any additional administrative costs related to reform prior to fiscal year 2014.
All right, that billion, 1.7 billion from 14 to 2020, is that what I understand?
It's really from 2011 through 2020.
2011 through 2020.
Right, but we haven't had any expenses incurred for healthcare like that. Through 2011. But there are some changes to healthcare reforms that are not just related to eligibility.
I guess one of the numbers I'm interested in is when it begins to go into effect at 14, what might we see then when you've got an additional potential? Everybody's not going to sign up at one time, so we're not going to have 300,000 new Medicaid recipients.
We may or we may not. Hopefully we will not.
I understand, but let's just say we've got 100,000. Does anybody have any numbers to indicate starting in 14, which is something that we can see and understand what we're looking at regarding a budget effect with 100,000? Let's say just roughly that we don't get all 300,000. 100,000 come on board by 2014. Is there any projection by Medicaid of what that cost might be?
Governor, they are coming on now at the rate of about $2,000 per month. So expect that to continue. We don't know whether we'll have a blip in 2014 or not, but you can take the number of beneficiaries we have now and add, say, 2,000 a month to whatever you're concerned about, or you can divide the number of beneficiaries we have and then the amount of money we're spending and get a rate per person, per beneficiary, like we've got in here, and you multiply it out and get as good an estimation as you go and have.
All right, you're telling me that beneficiaries coming on Medicaid now at an additional $2,000 per month?
Yes.
Right.
We prepared this last slide just outlining our recommendations to improve the Medicaid program. We strongly support the implementation of APR-DRGs for inpatient hospital payments and APCs for hospital outpatient payments. We recommend a continuation of the freeze on institutional long-term care rates. We believe the state needs to continue to strengthen program integrity efforts. And finally, we recommend aggressively pursuing Medicaid fraud enemies. This concludes my presentation. If you have questions, we'll be glad to try to answer them.
All right, questions? Mr. Davis.
Thank you, Governor. Go back to the first page where it says projected increase in growth of Medicaid services. We're anticipating, according to this document, a 7.4% increase. Is that right? And how does that compare to 12? What was the projected increase?
It's approximately the same thing in 12. The rate of increase.
That is actually our 12 requests that we ended up adjusting throughout in the year was actually lower than 7.4%.
I was thinking it was lower. And then, but where did this 117 come from?
Well, it's the calculation that you make if you increase the growth by 7.4%
What,
by all the provider
763?
payments.
The 763?
No. It was an overall calculation of expenditures expected to be made to providers, where it increased over and above what we projected for 12, about 7.4%.
That number seems high, considering what if you go to between 11 and 12, there's only a difference of 13 million.
We used that 12. The 12 estimate was based on growth as of March to date, and FY11 growth actually sped up after that point in time. So our 11 expenditures were actually higher than we predicted in March.
It's a lot of money. Thank you, ma'am.
It is. Senator, I think I recognized you early, and then we'll certainly go to Representative Flash.
Thank you, Mr. Chairman. Just briefly, and kind of along the same lines as Senator Davis here, and I think Representative Holland will agree with me, this budget, more than any other, is the most unpredictable budget you can ever imagine, because the numbers do change every month, and it's up and down all across the board. I've heard estimates anywhere from $300 to $350 million more in state dollars for the Affordable Care Act as a possible increase by 2015 or so. And, that guess is as good as any other. It's as good as any guess we can give as to what we might need in 2013 right now, because we just don't know. We're just doing, I know you're putting together the best package you can, but this figure that you have up here in front of us, given the fact that it is such a volatile budget, is that a pretty close guess to get you through as of right now? I know it may change before the end of the session.
It's the best we can put together. But what's happening to us is they keep changing all the time. I get 3 or 4 communiques from CMS every day. Two of them are corrections on what you told me yesterday. And then they just make huge changes that affect everything, what you're doing. And this is the reason we haven't been able to get our MMIS RFP out on the street. Is we'll get it prepared and they'll change what they want, what the most